Yep.
Right.
Okay, let's go. So thank you very much to everyone who's come to this meeting today. It's great to have you here. So I'm Karen Graham, and with me is Karina Schaefer. And we are both members of the GIN Public Working Group, and we are co-authors of the chapter of the GIN Public Toolkit, which looks at patient information, which is derived from guidelines, hence us doing this workshop. So today, what we'll do is we will present to you, and then we will open it up for some discussion. So when we're presenting, if you do have some questions, if you could pop them in the chat box, and then once we've presented our slides, we will then open it up over to you for discussion. So I'll just go through, as I say, what we're doing is we're presenting on the GIN Public Toolkit. So we updated our GIN Public Toolkit in September last year. And what we'll do is we will continue to update that. But what we're going to do today is just talk about what we've got in the chapter on patient information. Sorry, my slides are going ahead here. I don't know why. There we go. So the objectives of today's workshop, we're going to share our methods and good practice that's highlighted in the GIN Public Toolkit. We'll explore some of the products that we've highlighted in that toolkit and how we've developed them and how you can develop them if you're coming to do that. And then what we'll do, we'll discuss some ways of involving patients in the public when you're developing patient information from guidelines. And then we'll think about what we still need to do, because there are challenges when we're producing information for patients in the public. And we'll have a talk about that with you to find out from you what challenges you might have and any solutions that you have to them as well. So communicating guidelines to patients in the public then, so there's different products that we can use when we're producing information from guidelines for patients in the public. And we mentioned a lot of these in our toolkit. So these range from plain language summaries, we produce patient versions of guidelines, and of course patient versions of guidelines are not just one thing, they can be multiple formats. So it can be booklets, it can be videos, it can be various things, and we'll talk about some of those as we go along in the presentation. Patient decision aids are another thing that can be produced for patients as well from guidelines. Interactive summary of findings as well, where we can present key messages from systematic reviews as well. And of course, you can promote single recommendations. And again, you can do that by having that in a leaflet format and so on. And fact boxes and decision boxes are another type of decision aids that we can use information from guidelines as well to help patients to make decisions about treatments as well. Okay. So process for developing guideline-based materials for patients in the public then, as we've highlighted in the toolkit, to do this, you need to have a collaboration of clinicians and patients from your clinical guideline group. And of course, there can be other patients involved in that process as well, but we can talk about that further on. It's really important when the clinicians and the patients, when they're deciding what they want in the product that they're producing that came from the guidelines, it's really important that they decide, oops, didn't mean to do that, they decide together what is important, because what clinicians might think is important isn't what patients might think is important. So it's really important that they make that decision together. And to select the recommendations for inclusion, what they need to do to prioritise is think about what recommendations can people influence, are there recommendations that can empower people to make decisions about their treatment and so on. But also when you're producing something for patients in the public, it's really important that you get that language right. And although clinicians are involved in that process, it's really important that whoever is putting that together doesn't have a clinical background, or they may have a clinical background, but they must have experience in writing for patients in the public, because it's very different. Because clinicians, they use a lot of jargon, so they might not put it in plain language. So in different organisations, at NICE, for example, they have a team of people who are medical writers, and they write the information for the public. At SIGN, what we do is the clinicians are involved in drafting bits of text, but then it comes to likes of me and some of my colleagues and we have training in plain language, and we have experience in writing information for patients in the public. So that is something that is really important when you're producing information for patients. When you're producing information for patients, it's very important that you use some quality criteria. So for example, the International Patient Decision Aid Standards, that's something that looks at, when you're producing decision aids in particular, that they're specific to decision aids, that, looking at the content and making sure the quality is right. So does it produce sufficient details about the options? Does it highlight the benefits and harms, and so on? And, is there a systematic development process in place? Similarly, the Patient Education Materials Assessment Tool is an instrument that assesses the understandability and also the actionability as well of print materials and also audio-visual materials. So again, it looks at, would patients be able to understand the, what they've got in your material? So is the information clear? Is the purpose clear to people? Is the information in chunks? Is it broken down so that people can understand that, and so on? So there's various tools. One of the other ones, one that we use at Sign, is the Discern tool, and again it looks at the quality of the information, and it has checklists in place so that when you're producing your information, you can use that checklist. Again, it's really important to ensure accessibility as well, so different formats of information and translations and that sort of thing, to make sure that people can access it. And it's very important when you're producing information for patients in the public that you have a consultation process in place for that. And in the GIN Public Toolkit, there's various information on consultation, and there's different forms within that as well that people can use when they're consulting with patients in the public, because you want to make sure that the information that you produce is usable by people and it's acceptable by people as well. And then once you have your product, whether it's a patient version or whatever it is, then there's evaluation is really important as well. So you can look at it, you can get feedback on it. Then when you come to update it, or you're producing other ones, you can use that for improvement purposes as well. So what information should guideline-based materials include then? So the qualitative research that we looked at when we were producing this chapter in the GIN Public Toolkit was people wanted information on the context. So who is the information for and what is it about? That's something that's really important. You want to make sure that the people who are reading your materials or looking at it, that it's relevant to them, and they're more likely to pick it up if they feel it is relevant to them. Background information about the condition, that's something that in our research and other qualitative research, that can I just get everyone to put themselves on mute, please, if you're not already on it? Thank you. Background information about the condition. So patients not only want information about recommendations that the guidelines have come up with, but they also want a bit of background information about their condition as well. Your material should have diagnostic and treatment interventions, so information on that. What are the treatments and what are the risks associated with them? The other thing that people want is self-management information, so something that how can they help themselves, so information on that, but also signposting to other sources of help. So a lot of the time in your products, you'll be able to, you'll have your information from the guideline, but then if people want other information, then you would want to highlight to them where they can go. And again, coming back to quality assurance of that, you would want to make sure that wherever you're signposting people to, that the quality of that information, the quality of their website is reliable as well. So you would want to do a quality assurance check on that as well. How the information was produced, again, people would want to know who produced the information, is the organisation credible, and that sort of thing. There is a need when you are producing information for patients in the public, although it's based on your guideline, there is often a need for additional information. So your guideline might not have that. So you might have to, again, have a look to see what additional information can you put in there that, again, is reliable information. And it might be that you make a recommendation about a treatment, but you might need to put some additional information in to describe that treatment. Or, if it's a test, you might want to, again, explain that test so that it's really useful for people who are not aware of what that test would involve. So presenting information to patients in the public, in your information, you would want a structured presentation using questions and answers, and that is of value. Again, that came out of any, the qualitative research that we looked at, and also the qualitative research that we did ourselves as part of the general public work as well, or the research project that was fed into this toolkit. Tabular format was useful for patients in the public. Again, it allows them to make comparisons very easily if things are in tables. And use of symbols and words to convey the strengths of recommendations was something that was important for people. But again, if you're using symbols, you have to make something that's very clear to people, and you have to have a legend in there as well that people can understand what the symbol means. And if you're using words, they need to be quite simple for people as well. The use of layered approach for presentation of information is something that we recommend in our toolkit as well, so people can look at information, the most important information first, then people can drill down to other information. And again, it might be that have a large document, but you also have a smaller document as well with information in it. Graphics need to be producing the information as well, and graphics are something that are welcomed by patients in the public as well. They break up text and make it a bit easier for people to understand. But again, if you're using graphics, they've got to be relevant as well so that people can relate to them. So multiple formats are needed if you're producing information to ensure that we have accessibility and of course findability. So how is that information actually going to be found? Is it going to be handed to them by a clinician, or are people going to find it themselves on websites and things? Colours, fonts and graphics are something that needs to be appropriate for your target audience, particularly to ensure accessibility as well. If you have to look at the colours that you're using, and of course your font size as well. Use of quotes can be really useful to personalise information for people. In our DECIDE research that we were involved in, it's something that quotes can be really useful for people. But again, you've got to be very careful if you're using quotes in your information to make sure the quotes are representative. So something that you have to carefully think of. So at SIGN, we produce a range of information for patients in the public. So we do patient versions of guidelines. So for every guideline we do, we have an accompanying patient version. Usually that's in booklet format, but we have done video formats as well. Apps can be useful. So we have done one recently at SIGN on long COVID. And within that app, there's an interactive symptom diary as well. So you can do things like that from guidelines, which of course are useful as well. And again, it lets people take control of their own condition. Information leaflets can be produced as part of your guideline. Plain language summaries, we've done that at SIGN as well. And easy read documents for people with learning disabilities is something that we've produced quite a few of recently. And of course at SIGN, we always translate into alternative languages on request should people need them. And this is just an example from our so a booklet for families and carers, but then we decided that actually there was a need for more than that. And there was a young person who was involved with us, and they said, well, actually, I think you really need something for young people as well. So we produced an animated video and we incorporated the patient story into that as well. So who was involved in developing this information then? So again, just like I said at the beginning, we had clinicians and of course the people with lived experience who had been on the guideline group. They were involved in that process. But in addition to that, we recruited a young person who had fetal alcohol spectrum disorder. We recruited her to work with us to produce the video for young people as well. And that worked really well because she hadn't been involved in the group, so she hadn't heard discussions and whatnot. but she looked at the guideline and she was involved in selecting the recommendations that would be useful for young people to be aware of, to help them to make decisions about their care. We also involved a public partner who's a volunteer that's involved with SIGN, and they were involved as well to bring in that objective user perspective. So the role of patients and carers in this process, again, to select the recommendations and other information from the guideline. So this guideline was, we actually ended up basing our guideline on a Canadian guideline, and a lot of it was consensus recommendations. So we got them to go in and look at that to choose the information that would then go into the booklet and of course the video. So they did that. They also looked at some quotes that we could put in our booklet. So we had gone out as part of our work on the guideline. We had done quite a few focus groups with kinship carers, and we had collected a lot of experience quotes as part of that process. So they went in and they had a wee look at those quotes and they thought what would be useful to other people, what would be most helpful for them, and they chose them and we included them in that booklet. They also advised us on the tone and language as well for our booklet, which was really, really helpful. The topic's obviously very sensitive in nature, so it was really important to have them involved in that process. So the challenges with this guideline, there was a lack of evidence. Like I say, our guideline was based on a Canadian guideline and we adapted that, and a lot of the recommendations were consensus. So that was quite challenging because a lot of the time the patients on the group didn't really agree with what we were doing. There was a lack of evidence which the patient rep found really difficult to accept, and of course it was quite tricky to agree the wording because of the topic. So we had to try and avoid sort of stigmatizing this, and also we didn't want to use negative language that could be offensive to the birth mothers. Okay, I'll hand over to Karina now, and Karina will tell you about her work with the German National Disease Management Programme.
Yes, hi everyone, and 2 more slides and then we have done. So then we have a lot of room for discussion after that. I'm just providing you another example from another context, which is from the German National Disease Management Guidelines Program. And I'll just report on the patient materials that we have for our guideline on chronic coronary artery disease. Like SIGN, we also provide a broad range of patient-directed tools, which is a patient version of the guideline. And with us, the patient version of the guideline is definitely a kind of translation of all the important recommendations, the rationales, the underlying evidence, and everything for patients. So that is quite a booklet. It provides very useful information when you are at a specific stage of the disease, because there are a lot of interventions and recommendations in the patient version that you would not find in any normal usual booklet or leaflet in any kind of information on coronary artery disease, because they're very specific. So this is quite a difficult format because it's a very long brochure, a long booklet. It's available online and via PDF, but it's quite some work to read and to work through all these pages. So we assume that, and what we know from our evaluations is that this is that's okay for people who are very interested to go into their disease and to understand most of it, and who are, especially people who are at the later stage of the disease. For them, it's more interesting because a lot of information in there, which is for late stage disease, cannot be found elsewhere. But we know that this patient version of the guideline, this very large booklet, is not a format for everyone. So what we do is also we provide short information leaflets that just give a broad overview of the condition, of how diagnosis and treatment in general are like, also based on the guideline and also agreed on by our guideline group. And these are designed in a way that GPs or any treating physician can print them out and send them out to the patient. So we definitely want to encourage the distribution of information material via the GPs or via the healthcare professional. We also provide information for specific clinical situations. Some are decision aids, like should I take a statin or not? And then the next step, what do I do when the statin doesn't work? What about other medications that might be available or so? But we also provide decision aids on revascularization. Do I need a cardiac catheterization? Is a lifestyle change useful? Should I stop smoking and all these things? We also provide self-management support information on specific aspects of the disease, like what do I do in case of emergency? How can I help if I'm related or so? And we also provide support on how to take medication and so on. So these are all small leaflets. They are all available online as well and via our website, responsive website, so that you can read them also on mobile devices. We translate, as Karen also said, our information in only 6 languages. These are the most important in our migrant communities, which is Arabian, Russian, Turkish, Spanish, French, and English. However, there would be others that would be interesting as well, but as all of us have limited resources, we decided to focus on these. And when we do these translations, we also have learned it's tricky because we always want a native speaker to that has a medical background to check the translations that have been done by official and accredited translators for medical conditions. But however, through this double check, we see that there is a lot of need for change, because not all of the translation drafts that we get are purchase sensitive. And so sometimes there is definitely some need to change. So this kind of translation is quite resource demanding. And what we are testing right now is whether the use of any automated translator like DeepL, I don't know if you know that one, which is quite interesting because it's a very great learning artificial intelligence, or even Google Translator, are sufficient for all purposes or not. Because of the resources that are going into translation, that's quite a tricky thing. We might spend them in a better way, perhaps. We're testing that right now. We also offer, as Karen said, information in a very simplified language for people with cognitive impairment or learning disabilities, which is more than just plain language, because it's definitely these 3-word phrases and using the same term for any kind of object every time, so not changing the words and so on. And it's quite complicated to explain complicated facts regarding the disease or algorithmic thinking through this simple language. So you definitely have to decide what is very, very important and what information definitely has to go into this kind of information type with this simplified language, and what does not, because it always gets longer than the usual information, because you have to try to explain in so many different short phrases. So that's very tricky as well. And you have to be careful that it's not too directive, pushing people in one direction, because the simpler you get, the more tempting it is saying do this or do that, and not offer the chance to decide. And we also have developed online decision support tools for GPs, which is not something like that guides the GP decision, but helps the GP having the consultation, the discussion with the patient. For example, we have one developed for the use of statins, and the GP sits in front of the desktop together with the patient, and they have a look at this tool, and you enter the individual risk factors, and you have a kind of a calculator that says what broadly the risk of developing, for example, myocardial infarction would be. And then you can decide together if that risk is with taking a statin or not. So this is the kind of interactive tools that we offer. And the chance here is that you can, to a certain extent, individualize decisions and risk communication. Yes, Karen, and I would like to have the next slide. If you could. Yes, and so like Karen did, I'll also share the experience with one of the informations that was derived from that guideline, which is a decision aid on catheterization, cardiac catheterization for stable coronary artery disease. The background for this decision aid was that we know that, especially in Germany, we have far too much cardiac catheterization in the process of diagnosing coronary artery disease. So we definitely have an use of this procedure. And we think that if people understand how their risk is and when it is recommended and when not, that many of them would abstain from demanding that procedure. So that was basically the background. These are short information leaflets, type of option grid formats. I don't know if you know that format. It's just a table presenting the different options and comparing them with regard to some clinical questions like, will I live longer, or what are, how does it affect my daily life, or this type of questions. And you find very short answers in that table that compare 2 or 3 or more options. So that was the format that we used. And we also translated this into an interactive online decision support tool, as I explained before. So who was involved in developing that kind of information? We have clinicians from all relevant disciplines. We had nurses and people with lived experience from the guideline group. And this is something very important. I don't know if you all are working in the same way when we have topics that are very conflicting, where there are very conflicting views on specific, for example, interventions, like here it is, PCI. So yes, PCI is the word for stenting, and for the cardiac catheterization. We definitely need to have all the different views in our group in order to find the consensus that is supported by the large majority of all of these groups. So it's very important for us to have all these large multidisciplinary teams. And we also, as Karen said in the very beginning, we have information specialists and medical writers at our institution who are involved in drafting the different formats for patients. We also have, I didn't mention that here, but also we have our online specialists who translate this into our website. And we also invite lay and expert public via an open consultation to comment on the drafts. So not only for the guideline, but also for the patient material, we have an open consultation like for 6 weeks or so, and then we collect all the comments and see what we need to change. And as Karen was talking about the patient role in the development of information, I just want to highlight, because I don't want to repeat all the same things that she said, I want to highlight the clinician role in the development of information. And what we do is all the patient material that goes out for a specific guideline is agreed on in the whole guideline group. That means we have to have full consensus on all the material that's going out. So for clinicians, it's sometimes very tricky to agree on lay language for translating complicated evidence about, for example, uncertainty. And I think there are different reasons for that. To my experience, one is that some of these processes or some of the facts that we try to explain in easy language, some of these are, in reality, they are so complicated that very often the experts say, that's too simple. You cannot say it like that. And it's with all their expertise and background that they feel sometimes not at ease with simplifying too much. That's the one thing. On the other hand, we've also learned that once you use this simple language, a lot of clinicians and experts understand better than in all this jargon how the real effects of an intervention are. And here, if you as a patient have to decide whether or not you want a cardiac catheterization, you have to understand the harm and benefits of cardiac surgery, so bypass surgery, or of stenting. And if you don't understand that, you cannot say whether you think it's worth having the risk of this intervention of the cardiac catheterization. And all of those clinicians who do interventions, they're so convinced that these interventions help that when they see in this simple language and this easy display of risk communication, how, let's say, how small the benefit might be, it's very difficult for them to agree on that. So that was definitely challenging. And what was even more challenging for the, and another very important role, sorry, for the clinicians was that we had to agree on subgroups of patients for whom the presentation of benefits and harms of the intervention would differ significantly. For example, like having people with coronary artery disease and diabetes, or having people with coronary artery disease and smokers, or so. And for some, we have quite good subgroup analyses, meta-analysis on the benefits and harms, and to choose those that are definitely clinically meaningful and significant was an important task of the clinicians. And the challenges, besides that, what Karen said, the challenges in this specific case was that there was so much uncertainty and inconsistency of the evidence. Because you have direct comparisons, you have indirect comparisons, you have only one trial that tested the intervention of having this catheterization, plus the emerging procedure, like either bypass surgery or stenting. And all the other trials just compared one of these two procedures with optimal medical treatment. So we had a lot of indirect comparisons, which weren't clear at all. The benefits generally were very small. So it was, sometimes it was definitely difficult to decide where you would, what kind of certainty you would accept, and to translate this uncertainty into lay language and conveying this to patients led also to the fact that some of them were so disappointed by interventions that we thought were definitely helpful, like taking statins, for the majority of people affected with coronary artery disease, that that was questioned whether that was definitely helpful to provide the absolute numbers and the risk communication. What we definitely do every time, but that was definitely challenging here. So there was a lot of overestimation of the clinical benefit, and that overestimation we found in patients and in clinicians. And this is definitely more difficult to discuss when you do this, when you explain this in a very simple language and you don't have all the maths and all the statistics behind, but only simple numbers naming the magnitude of the effect. So that were the challenges that we basically had for this specific decision aid. Plus, there was strong disagreement between the disciplines on the interpretation of the evidence. You can imagine that cardiologists are very fond of providing stents, and cardiac surgeons are very fond of doing cardiac surgery, bypass surgery, and GPs are very happy just having the people coming to the practices and offering optimal medical treatment. And as the evidence is so complex, we had so much disagreement that, and that is the final conclusion for here, that we definitely managed the guideline group to agree that treatment choice should be guided by the patient. So it was definitely clear that we offer all the options with the evidence that we have, and the patient himself should decide whether or not that was worth the procedure or not. Yes, so that was the challenge for the coronary artery disease that I'm reporting. And I think we're finished here, Karen, and we're happy to take your questions right now, aren't we? You taking over, Karen?
Yes, I am. I just cannot move the slide on for some reason. Don't know why. It seems to be stuck. Just bear with me.
I think we just had our email addresses.
We just had,
here.
yeah, there
Yes.
we go. I don't know why it's delaying, but there we go.
Perfect.
So that's our email addresses, just for people.
In case you have any questions or
You
want to
can
contact
send those
us further.
to us. But if you have any questions now, then you can happily pop them into the chat box, because we've got a question that we'd like to hand over to you and get you to have a think about what challenges you have when you're, oops, I've just lost that now. When you're producing information for patients and the public, what are the challenges that you have? So what do you currently produce, and what are the challenges you have when you are producing them? So
Yes, and yeah. As you have just stopped sharing the slides, I just encourage you to open your cameras, and so the way that we're not such a large group as expected, so
yeah, so
we can definitely see each other and talk to each other. And as Karen said, either you raise your hand, or you just put your questions in the chat box.
Yeah, we've got Patrick first. Patrick, would you like to come in?
Unmute. Okay, sorry, I was trying to unmute myself, but that wasn't working. Can you hear me now?
We can, yeah.
Yes, okay. So I think this is very interesting, and I think we were excited at DBase when we saw this webinar coming up. So we wanted to join, because we also have had a keen interest in engaging consumers in evidence or and understanding guidelines. We have this problem similar to what Karina presented with patients who actually prefer injection, despite the fact that the clinical practice guidelines are recommending oral medication, because maybe they have a feeling that the injections work better. So, and we are seeing a lot of ways that we can use this tool to adopt to our own approach. In essence, our own approach is using storytelling to communicate with patients and users about the need for using a health technology that's evidence-based from guidelines. And this works better because most of our target audience here are not literate. So telling them through a story about, for example, someone who decided to insist on not taking an evidence-based recommendation and how they could suffer a negative consequence because of that purpose. For example, somebody who needed an oral medication for malaria, maybe insisting for injectables, and because the doctor says that based on your diagnosis, what you need is a tablet, they would decide to go to the street to get an injection. And in that process, maybe they get an injection upstairs or something like that. So this is the kind of message we can communicate. And when I look at the toolkit of Gene Public, I can see that there are areas for decision aids. So those decision aids, those simple plain language summaries, those simple points could be very easily used in a story, in developing a storytelling that you tell the patient. So in essence, you roll out the decision aid, but in a story and in a local language. So the people get to grab the message well and in a non-confrontational manner. And I think there are some team members at DBase who would really use being membership at Gene Public. And I think one of the Penka was asking me earlier on, it would be interesting if we could also understand how to join. Thank you.
Yes, thank you, Patrick. Those of you who attended the last Gene conference know that Patrick has held a keynote on storytelling that was marvelous, Patrick, definitely. That was so interesting. But I just take the chance to ask you something. When you spoke about storytelling during the conference, it was clear that you have a very, very trained crew. They know that they understand evidence-based medicine. You develop these stories together. The question is, how many people do you reach when you start storytelling? The chance of providing this online information is that you can share it with a broad community. However, you don't know how it is understood or not. And what is your experience, Patrick, with the storytelling? How many people did you reach? Do you do it for larger groups, or how do you engage in conversations with these people? That would be interesting to know. I was trying to unmute you, Patrick. It looks like that didn't work.
Patrick, it looks like he's still there. I'm asking to unmute.
Yes, that's what I tried, but actually it doesn't work.
It's not worked.
Or you share it via the chat, Patrick, your experience.
I didn't get you. The line was breaking, so I didn't hear what you said.
Okay, the question was, Patrick, how do you reach other, and how many people do you reach? You have a very trained team. I know from your presentation, and they know all about evidence-based medicine. So you have kind of limited resources how to spread the stories. And the question is, do you have any experience how many people you reach? Do you do this storytelling for larger groups, and do you engage in conversations? And what is your experience with that? That was my question.
Oof, the line is what I could get is you were asking how many people I have reached.
Yeah, with the storytelling.
With this approach, and is that what you were asking? How many people we've been able to reach with this approach?
Yeah.
Yes. Yes. So with this approach, over a period of 1 year, we actually communicate guideline recommendations to over 10,000 patients, and we actually engage them in the process. We can communicate to 10,000 or more patients or consumers and clinicians. I actually included in that number. But the important thing that we always want to get is the proportion of those that are actually interacting with us, telling us that this is why I want injections, this is why I do not want tablets, etc. So we work with limited resources, and we actually, for the work that we do in the health sector, it's based on resources that's coming from maybe funding that we get from other sectors or other policymakers' problems that they want us to use storytelling to address. So because we get that funding, we are able to use the
patient guidelines. So we work a lot of time together, and I'm very interested in getting to know the toolkit as Sophie. I am particularly interested in how we can get more patient involvement, because we have a patient panel who gives input for our guidelines for what they read it. They have instructions on how to read, and we want to know how they experience it, how they where they see improvement for language, and to make it more accessible for them and for the broader public. But yeah, I'm very interested in getting to know how we can benefit even more from their input, or how we can motivate or explain, and yeah, take that to the next level, because that's, I think, a very important part of our project. But it's not always easy, I think, to get most out of it. I'm not sure how to express it, and my kids are running around. I'm sorry. Bit distracted.
That's fine. That's involvement. So that's yeah. Thank you. Karen, you want to just comment?
Yep. So that's great, Iona. Thank you very much for that. And the other thing is, you know, if you were interested in getting involved with Gin Public, then we would be happy to have you on board as well. And then, you know, if there's things that you think, again, if you think we should be covering in the toolkit, then we'd really like to hear from you as well. So that's really good. So thank you for that. So Lauren, would you like to come in?
Hi, thank you. I was wondering if you could both talk a little bit more about the resources that you were both able to utilize to do some of these projects. And I'm thinking specifically, Sophie said, you know, it's just one person. So I'm wondering a few related things. So are the people who are working on the public facing materials also the people who are the guideline methodologists in these cases? Are these separate roles? So you have one person doing the guideline methodology and you have a separate person who works on public material. And also if you can, I know it's difficult to do this, but if you could talk about some of the timelines for some of the products you've talked about. So you've presented very large public facing products, but even an example like an information leaflet added approximately 6 months, you know, to a timeline, or and just any kind of examples you can give about both the human resources and how it impacted your planning and timeline.
Yep, so I'll answer that. So at Sign anyway, it's usually the clinicians and the patients who are involved in the clinical guideline group that get on board with the patient materials that we produce. So a patient version of a guideline at Sign in booklet format takes between 6 and 7 months to develop. So normally what we do is we wait until the guideline is at the editorial stage of the development process, so that you've got a sort of more or less full set of recommendations. So we wait and start to do that once the guideline's at that stage. So in terms of resources, like I said, the clinicians and the patients involved in the guideline group they form part of a subgroup to develop the patient materials, and they are involved in sort of putting the recommendations into a format that's understandable by someone who's not medically trained, such as me. So what they do is they put it into sort of simpler language. It then comes to me or someone else within my team, and we will then draft that into the patient version. So normally what we do is, like I say, it comes to me once they've drafted something, but that'll involve a lot of to and fro in, because again, they might think they've simplified it down and it comes to me, but then I might look at it and I might think, well, actually, I'm not clinically trained and that doesn't make sense to me. So I would then have to go back. So there's a lot of to and fro involved. So it does take quite a bit of time. It's really time consuming. And again, it takes so long to develop the patient versions of our guidelines because we are doing it with patients in the public. So the patients who are involved, they will comment on every draft of it, but it then goes out for consultation, and we usually allow a month for that as well. So that is really sort of the time scales that we work to for that, but it's all done in-house. And previously there was only me involved from the staff side at Sign. Now we've got a bit more involved. So again, it took slightly longer when there was only one person really sort of involved in the writing of them. So it really depends on the size of your team. So if you've got more people, then obviously say is definitely allow more time than what you think would be needed.
Thank you. I didn't want to interrupt you. You were just sorry. I just can add a little bit if that's okay, Lauren. What we do at our team, we have two people in our team who are specialized on like translating evidence into simple language. They have a methodologist training, Yes, so they are basically guideline methodologies, but they have a specific training in medical writing. That is what we do, and at our institution, it might be that like within Sign, we provide the methodologies for the guideline group. We organize the development of the guideline, and we invite all the panel members on the guideline group. We have these different nomination processes. However, the clinical experts come from the specialty society. Interested in working on patient material, and it's very, very useful. At some of the some wording that you're using, saying, well, but I know what you mean, that goes in the wrong direction, speaking in a medical way or so. So you definitely have to have the kind of clinical expertise to check the text. But I definitely admire, Karen, that at Sign, it's definitely the clinicians who do all the work. In our institution, we do it, and you were asking for the timelines. What we do is we start at a very early stage of guideline development. We try to identify those recommendations that are very, very sensitive to shared decision-making, and where the experts see some kind of lack of communication, or where they think people should be better informed. And we try to prioritize this kind of recommendation and say, wow, let's develop a decision aid for that. And as we want these decision aids to be integral part of the physician guideline, of the expert guideline, we start developing them along with the clinical recommendations. So once we have the evidence review and synthesis, we discuss the recommendation, and we translate this directly into a specific decision aid for this or that clinical recommendation. And this we produce alongside with the guideline. And for the other material, as Karen said, for the patient version and other material, we start when the guideline is in the stage of finalized draft and undergoes public consultation. And then it depends on how complex the guideline is. And as we have all these major chronic conditions, they are all very complex, and we have very large brochures, then it would take, like Karen says, like 5 to 6 months or so for the production of the longer materials. A shorter leaflet is okay, that can be 4 weeks, but always we always need the feedback from the clinicians. However, the methodologists at our institution, we definitely looked at those who are drafting the material have been present in guideline discussions, so that they know where the crucial points are. And if they are not, they are in very close contact with the methodologists who definitely accompany the guideline. And we do all the moderation, all the group discussion, so we definitely know how the discussion goes. And we kind of understand beforehand what the important topics are, just being through being part of the whole process. And I think this is the most helpful thing, understanding what the clinicians and the other healthcare workers say, and what their interpretation of the evidence is, and so on. This was the most important issue for us, and the most helpful thing for us when we were producing all this kind of material, definitely. But on the other hand, I know that resources for many guideline producing institutions are very scarce, and we know that we are quite happy having 2 people. It's like one full-time job, but shared by 2 colleagues, that we are able to spend this resource on the production of patient material. And I know that in Germany, for example, many guideline groups produce their guideline without that kind of support, and they even try to provide some patient material. And that is mostly clinicians that are very enthusiastic, that provide this kind of information, and it's all done in their spare time. And that's definitely something one has to acknowledge. Okay, I see one question in the chat. It's from Lindsey, saying the presentations highlighted insufficient or low certainty evidence as a challenge to developing patient materials. Can you discuss strategies to handle this issue? Yes, Karen, that's a tricky question, because I just share my experience here. What I have learned during like 10 years of production of patient material is that once you start to use lay language, you tend to put more value judgment in and saying this works and this is what you should do, and this helps so many people and so. And what I have learned is the more complicated and the evidence is, and the more uncertainty there is, the more important it is that you're purely descriptive, saying this is what we know, and it's even difficult to say studies show that, because if you write they show that, you believe that's true, that's in the study. But if you say like studies may be studies may have shown a kind of benefit, or this may help you or could improve or is likely to be beneficial or so, this is a bit more helpful, and that helps translating uncertainty into language. And I think Cochrane has provided quite an interesting matrix, and I think great as well, how they translate specific grades of evidence certainty into lay language. However, what I've learned is definitely the most important thing is to understand where the value judgment comes in, and to be as neutral as possible and as descriptive as possible when you are dealing with very low certainty of evidence. And if you don't know it, just frankly say, we don't know if. That's the easiest thing, but that's hardly acceptable for a lot of focus groups that we had, saying, how comes you don't know? Because it's very hard for many people to accept uncertainty when they think medicine is a science that always has a solution. So that's my experience. Karen, you definitely want to add, or anyone else from the group?
Yeah, I would agree with that, Karina. I mean, a lot of the time, you know, we will put in our patient versions that we've looked for the evidence, but we've just not, you know, there's no evidence available, so that people know that, you know, it's not just been completely overlooked. I think it's important for people to know that we have looked and there's just no evidence there. A lot of the times as well, there may be a treatment that people, you know, that people use. We've had a lot of that on some of our guideline groups, that people have used treatments and, you know, they're disappointed that there's no evidence for them. But what we will say sometimes in our information is that, you know, there may be treatments that people do find helpful, but there's just not enough evidence for them, so that we are actually mentioning it. And sometimes we often mention those treatments. You know, I think in our UTI guideline and our patient version, you know, the patients were very keen that we put a recommendation about using cranberry products and things like that. And so we did say that, you know, people might find them helpful, but we didn't find, you know, the evidence was pretty low. So people are aware that we have considered them. So does anyone else have any experience of that?
Looks like that at least somehow answered your question. I think this is what Karen also said. It's definitely a conflict between being honest and saying what you don't know, and responding to the needs of people reading your material. And I think there's a lot of need for education to make people understand that even though you don't know exactly, you nonetheless offer interventions, because sometimes you know that not reacting is worse. But this is very difficult to explain to, let's say, a broader audience, that once you are not completely sure what the evidence or what the intervention does, that you offer it, or that you at least take it into account as an option, maybe not the preferred option, but one option. And even if you cannot give a very clear trade-off. So I think managing uncertainty and communicating uncertainty is very difficult. And I'm not sure, I don't know what your experience is. Maybe this is also due to the fact that many clinicians, many GPs have difficulties saying, I do the best I can, but I'm not always sure that that's the best thing there is. So definitely admitting that you don't know, or admitting that the scientists do not know exactly, is really difficult. And I think during the pandemic, we have seen how much uncertainty is challenging, and also causes some kind of irrational responses to specific interventions. So yes, this is one of the important things. And the other one is communicating effect sizes that we as, let's say, methodologists, experts or so think are pretty good. And when you translate them for lay people, they say, what? Because I found the most interesting reaction I've ever had was when we did that decision aid on statins, and we provided factors on the effects of statins. And when you see that you have like a 3% reduction in total mortality for people with coronary artery disease, you'd say like, wow, this is definitely something. You have an intervention at very low cost, at very low risk of serious adverse events. And then you have a benefit of like 3% of mortality reduction within like 4 or 5 years. I don't know, I don't remember exactly, but that was the range. And the expert said, wow, this is definitely something. And when you translate this to patients, they say, what? Only 300 in 5 years? I won't take that. And this is difficult to explain to people that saying, yes, basically you're right, it's just only 300 in 5 years, but that's the best we have. And that's more than with a lot of other interventions that are so plausible to work, but this is the evidence that we have. So very often we disappoint patients when we communicate harms and benefits, especially when we communicate benefit. Okay. Any other questions or experiences you would like to share? Or issues you would like to see in the toolkit in our chapter on patient material? Karen, your comment?
What about, does anyone, have any sort of experiences of, working with patients in the public to actually, to find out what people want from, if there's a guideline, has anyone found out is a booklet the best format for people, or do people prefer videos or something else? Does anyone have any experience or done any sort of research around that? I think Martha, would you like to come in?
Yeah, good afternoon. Yeah, I actually work at eBay as a storyteller and equally as a researcher. So at eBay, just as Patrick rightly said, I don't know if you can hear me.
Yes.
Okay, yeah, so at eBay, as Dr. Patrick rightly said, we use storytelling, especially in the rural communities, because most of these people, they don't have access to internet. They are just there and they can't even read. So, and also within the African context, storytelling is part of us, it's part of our culture. So that is what people use to educate, to communicate, especially in rural communities. So that is what we have been using in order to communicate guidelines to patients in rural communities, what they have to do and what they do not have to do. So using storytelling is actually good because we use the local traditional storyteller. It builds a certain level of trust between the community members and the storytellers from their community. And there's an easy communication of the guidelines because they use their local languages. We all know that Africa is made up of thousands of languages. So using local storytellers of each community ensures that the guidelines are communicated to the community members in a way that they can understand, in a language that they can understand. And using the community storytellers, build that relationship of trust, because they all communicate together and they know that we belong together. So that is what we have actually been using, because we cannot just go with the literature, with the scientific language to communicate to them. It might be hard for them to understand. They cannot read it. So that is actually what we have been using, and we feel like in that context, storytelling is actually very much relevant. Thank you.
Thank you. That's really interesting. I think it's something that's, you know, I think it's a great way of getting the message over to people in a way that they will understand and relate to. So I think it's great. And it's something that we've been looking at SIGN is using patient stories to try and get messages over to people. We've not gone as far as you, but I think that's great. There's a lot of learning to be had from you, so that's really great. Anyone else?
I can just add what some of our colleagues have tried, which was not really as successful, was starting doing comics on specific guideline topics or healthcare issues that were very easy to read, and especially for a population that was not too used to read longer leaflets or whatever. However, you have so many, when you start also with like this kind of comics and you drop pictures, there are so many domains coming, different domains of meaning, and the choice of colors or the choice of persons or whatever, all this is full of information and has to be very carefully chosen. And so we learned it's quite tricky to work with these kind of comics, and how do people look like and what their faces look like. And so there's so much of judgment you can put into that. And you have to be very careful. And on the other hand, those specialists who are working with who were drawing cartoons and comics all day, these are their basic tools, definitely evoking emotions, and so that was something that we have to learn. And I definitely admire your approach to use this kind of storytelling that everyone's used to, and that you were so trained to use it in a way it supports evidence-based medicine. I think that's definitely a great achievement. So yes, congratulations. I think we have another raised hand from Radin, as far as I see. Try to unmute you.
I'm unmuting myself.
Great.
Maybe you will be able to see me soon.
Perfect.
Okay,
Hi.
oh, good. Hi. I'm not sure whether it's useful, but I've got just I'm a stroke neurologist, and I've got a full cupboard of these things. And you ask for examples, so I got this nice like video thing. It's not charged now, so I'm just talking to patient about some guidelines, and then after I talk to them, so they've got the sort of verbal information, so just leaving them with this thing. And there's a story about three people who had a stroke, and they've got atrial fibrillation. They need some anticoagulation. They need to make a decision, informed decision about what's the best choice, and so on. So they can just put these things here. I don't know whether you can see it. So they can they can just play the videos, and it's for elderly people who can't hear, so they can just put the volume up and down, and they can just go back and forwards and looking at it, and then we can discuss it again. And even my 5-year-old daughter loves it. So this is what one of the things which are useful. So this with the patients, we need to use multiple strategies, because there's lots of different patients. Some highly educated patients, they would accept I don't know, an article from Lancet, so I can just paint it and give them the Lancet or BMJ. They are producing the rapid guidelines with nice graphics. So this is what I'm usually using as well. But
But may I just ask you,
Mm.
when you showed this video, who did you produce it with? So who helped you translate this into a video? And did you put in your spare time, or was it a funded project? Or
No, so
that's interesting.
it was a patient education video created by Pfizer and Bristol
Okay.
Myers Squibb. So it's a commercial video, but
Okay.
but there's nothing nothing commercial in it. Otherwise, I wouldn't use it if it was an advert for medication. I wouldn't use it. So
Mhm.
because we are very cautious about conflict of interests. Because I'm a doctor, but I'm a guideline developer as well. So
Yeah, but that's right, because these
Mm.
companies, they definitely have the resources that go into this kind of material, and they have so much experience because they have psychologists on board, and they have marketing specialists, and people definitely know how to
yeah,
how
so
to
basically
communicate.
we don't use even pens with
Mm.
names of the companies
Mm.
or these notebooks or something. So no names of companies, no names of drugs. Because everything is generic. It's generic
Yeah, but
names.
when you just showed it, I said, "Wow, that looks so professional." Who did that? That's what I wanted to know, and
Yeah,
I understand that. Yeah,
they did
sure.
it.
But it's
But
great that you found it and that you find it helpful. It's no kind of criticism at all.
yeah, but
That looks
it's safe in terms of conflict of
yeah,
interest for sure.
great,
So I'm happy to use it.
great. So this is also something that's important to know where the good stuff is, because you don't have to produce everything yourself. Sometimes it's definitely helpful to
What we
see
are doing
where.
now, we are developing guideline on autistic spectrum disorder
Mhm.
disorders, and it will be so we are just adapting in the Czech Republic back home, adapting the NICE guidelines,
Mhm.
and we'll need to tailor the sort of patient's guidance for the population there, which will be quite difficult because the autistic spectrum disorders it's quite tough and hard topic, and then make some public information understandable for different type of populations will be quite difficult. So
That is quite
challenging.
difficult. We did some stuff on autism spectrum disorder a number of years ago, actually, and we've been thinking, when we come to update it, what would be the best sort of format. We've actually got three. We've got one for adults, one for young people, and one for parents and carers, but they're all in booklet format. And we've sort of been thinking, what would we do next time round to make it more sort of suitable, especially for the young people. What would we do? But just that what you showed there, that was my first thought, was how much does that cost? But obviously, if Pfizer was involved, then there'd be money there, because we're always finding that signing, I'm sure all of you and your organisations are probably faced with the same challenge, but money is always an issue at Sign, so we're always quite limited with what we can do. So roughly, how much did that cost that you produced?
Of the
If it's okay to ask that question.
which one? You mean the autistic spectrum? I've got the quote from NICE.
No.
So we are adopting or adapting two guidelines from NICE, and it's altogether 15,600 something pounds. So just for a license, which is fine, because it's just the quality is high, so
Yeah.
better than
That's
developing new guideline. It's just pay for the license, and we've got the grants from the Czech government, so it's fine. And it's not the first NICE guideline we are adopting. It's much better. We are adopting guidelines from for example, Australian Stroke Foundation for free. So we are just doing it together. They've got living guidelines, so we are just doing it together, and it's for free.
Yeah, makes sense.
You've done the autistic guidelines, the public information for NICE, for Sign, is it?
Sorry, what was that?
For Scottish, for Sign.
Yeah, for Sign.
Okay.
Yeah.
Yeah, Iona also says that she struggles most with translating guidelines about mental health issues because it's so hard to find the right tone. That's what you said, Karen, with the alcohol syndrome. Yeah, definitely. However, if I have a look at the time, I think we're nearly over.
Yes, but
Over
that's
time.
been really, really helpful. And although we didn't get the numbers that we had signed up, it's still been really helpful to hear from you and hear about your experiences, and definitely get in touch with Karina and I if you can think of anything that we should be thinking about when we're coming to update this chapter in the toolkit. So do let us know. But it's been great to have you here, so thank you very much for coming along.
Yes, and we on Karen's slide, you found our email addresses. You can also contact us via GIN or the GIN Public Working Group. So if there were any more questions or also any kind of ideas that we should pick up with in the GIN Public, we are happy to receive your feedback. We definitely invite you to join the working group if you're interested in not only patient material, but also how to involve patients and the public in guideline development. This is our main focus. The email addresses, yes, I just post them in the chat, if that's okay. And you just wrap up, Karen, and I just
Yeah, absolutely.
you might need to post your email address because yours is so long with the NHS. So this is mine.
I'll put mine in as well.
And you put yours in the chat. And so I'll just do a very short wrap up what we were discussing. So Karen just referred a little bit on the quality criteria and standards assessing tools that there are for patient material. And this is quite helpful to have a look at these. If you start with drafting patient material, however, we found that there are some challenges to the production of patient material, and which is what I learned from Sophie, is that in many guideline processes, this is not prioritized. And so there are no resources. And on the other hand, it's very important to understand that once you want to produce good patient material, you need resources and someone who's definitely knowing how to do medical writing, how to do journalism, and how to handle easy language and so. We just saw with the Pfizer material how helpful it is if you have definitely professionalists who know what they are doing. We said that it is very tricky to communicate uncertainty. This is one of the most important things, and especially the Cochrane collaboration provides some nice material how to do so. You will find that in the toolkit as well, in this chapter on patient material. But reflecting on your own position, on your own view, and that's helpful when dealing with uncertainty. We also were discussing the role of different people on the guideline group in producing patient material, and it's definitely helpful to have them all on board. You need the expertise in writing, you need the clinical expertise from someone who's checking, and you need the patients and carers and relatives that help you guiding through the process and highlight what's important for them. So that would be the most important things that we have been discussing. Karen, you want to add anything?
I think you've summed up really nicely, Karina. I mean, I think there's so many things to think about when starting to produce information for patients and the public. But I think the key message is making sure you produce them with the people who are going to use them, and to make sure that you know that the wording is correct, and you know if you are going to do it, then I would definitely say to use the information in the public toolkit, and do that to get your structure and so on. But I think that's probably it. I don't think I've got anything else to add, Karina.
Okay, perfect. Is there any remaining question from your part? If not, we'd definitely like to thank you, and we were definitely not 41 people who have signed up for the workshop. So there must have been some problems with the posted link. We'll check for this afterwards. I'm sorry if you had difficulties in joining us today. So thank you, either good night or good morning, or have a nice afternoon, wherever you come from. And hopefully we'll see each other in Toronto. Yes. So thank you for today.
Thanks, everyone.
Bye.
Thank you.